Yellow flag, chronic pain type stuff. Yep, definitely. What else? What else? Think non-musculoskeletal now. What are the things that can cause knee pain that's not related to tissue trauma?
Neurological?
Yep, potentially. What else? Cancer, I hear you say? Yep. Okay, what else? Rheumatology. So if someone's got an ankylosing spondylitis, rheumatoid arthritis, like any of those inflammatory conditions. So if someone has a degenerative knee, there'll be a pattern to it. If I go for a walk, my knee gets sore. If they've got something that's a bit more sinister or a bit, more of a disease process, there won't necessarily be a pattern to it. It'll have good day, shit day, and it's irrespective of what they've done. Okay, so if you ever get that sort of a scenario where you just can't pin it to a pattern, you're better off, especially in the early days of your career, you're better off getting someone to refer on. I had a guy a couple of years ago, a young rugby player, who swore he got hit in a tackle, and afterwards he felt like he had this lump in the outside of his shoulder. It was in a really weird spot. It wasn't near his AC, wasn't really near anything, it was kind of just over onto there. And it was fine, except if he got bumped on it. Okay, he could do weights, he could do everything. Couldn't reproduce, he couldn't set it off in any other way. It just sounded like every time he got knocked on it. And it didn't, no pattern, no red flags, no night sweats, no fever, like nothing that would sort of twig you off. But it just wasn't right. It wasn't sort of fitting a pattern. He'd had an ultrasound that said that there was a calcification there. He'd had a physio who was dry needling it for about 6 weeks, and it came back as a osteosarcoma. So he had a big bone tumour that went all the way down, basically 3/4 of the way down down the way his arm. And I'm pretty sure he died from it. So if you get these, you'll get these things roll in. It might only happen a couple of times in your career, but you'll get these things that just do not fit a pattern. All right? And if it doesn't, refer on. Okay, age. Why would age matter?
You get degenerative changes anyway, don't you?
What's that? Degenerative changes anyway?
Yeah.
Yep. So that it can do that. What else? What about young ones?
They're not mature, trained. They're not necessarily trained, and they might have imbalances because they haven't trained.
Yep. Also, you get conditions that sit in certain age bands. So Osgood-Schlatters, you want to heard of that? So that's a self-limiting condition. It's in the 12 to 14-year-old bracket.
Severs is pretty similar as well.
Through the Achilles, yep. You'll also get ones from the hip that will refer to the knee. Okay, and we'll talk about those in a minute. Okay, injury history and activity history, that sets up your goals. Okay, so if someone wants to walk their dog, you're going to have a very different framework to they want to go and play at the Olympics. Okay, so you guys may not necessarily, have you gone through like a lot of clinical conditions with the knee yet? Okay, so I would suggest that depending on what the exposure is in your course, this is more thinking with your hat on for when you get out, if you want to work in these sorts of areas. These sorts of lists, basically do your own research and learn them to death, okay? Because the better you are with this stuff, the easier your job is. So when you start talking about your acute injuries, you'll get things like your ACLs, your MCLs, meniscal tears, chondral injuries, so cartilage, patellar dislocation, patellofemoral pain. Okay, they're all really common versions. You'll get a few weird ones too, which you guys won't have been exposed to yet, but again, you want to try and look these up. There's a thing called a spontaneous osteonecrosis of the knee. Okay, it stands for, so it's SONC for short. So it's in middle-aged people, somewhere around the age of sort of 38 to 40s, and it presents like a degenerative knee. So they get medial spontaneous osteonecrosis of the knee. So they get sort of medial femoral condyle pain, and what it is that it's a spontaneous. They spontaneously lose blood supply to the femoral, to the end of the subchondral bone on the femoral condyle. Okay, so they lose the subchondral bone loses blood supply, which kills off the cartilage over the top of it. So if you have someone who's, you're trying to rehab them and you're trying to get them going, you can kill off all the cartilage in the knee there because you're weight bearing in something that's not getting well vascularized. Okay, so if you get a 22-year-old with a sore knee, there is zero chance they're going to get that. If it's a 40-year-old, there's some chance of that. Now, it's not necessarily you guys who have to try and work that out, but be aware of that. Okay, so that's where the whole multidisciplinary thing comes in. Your sports physicians, your GPs, your physios, all that sort of stuff. They'll help. If you don't just assume that it's if you look at everything like it's a nail and all you've got is a hammer, you'll just do the same thing all the time. Try and be aware of some of these things that are out there. Okay. Like we were talking about before, inflammatory arthritis. People that have post-op, they'll get DVT, they'll get infections, all that sort of stuff. Okay, so if someone's getting an infection in their knee, what do you reckon that's going to look like? Red and swollen. Yep. What else? Heat. Yep.
They're going to impede their range as well.
Potentially, but if they've just got a puffy knee, it'll do that. What else? If it's an infection, what is it? It's a systemic thing, isn't it? So they'll generally feel unwell. They may or may not have temperature, not always, but they'll generally feel pretty crappy, generally. Yeah. Night sweats, fevers, that sort of thing. Okay, so medial side, MCL we talked about, meniscal. You guys are comfortable with a meniscal tear? Have you come across that? Yeah? No? It's fine if you haven't? No? Okay, so your meniscus is like a moon-shaped disc. So it sits, your knee is like two knuckles sitting on a plate, so you've got your medial femoral condyle, lateral femoral condyle, tibial plateau. So it sits like that. Your meniscus are two moon-shaped discs that sit in between and act as shock absorbers on the joint. Your medial meniscus is fixed, so it's anchored down, it doesn't move. Your lateral meniscus can move. So that's why it's more common to tear your medial meniscus, because if you get a sort of a grinding action on your knee, your medial meniscus has nowhere to go, so it can kind of tear a flap in there. Okay, is everyone okay with that? Yeah. Don't worry about some of these, don't worry about those. Okay, so lateral side, so people can who have a PCL injury, posterior cruciate, can get lateral joint pain. You've got this thing called your posterolateral corner of your knee, which is made up of the joint capsule, your lateral ligament, your popliteus tendon. So it's all basically this back corner of your knee. You get a few structures that kind of add stability to your knee. So normally the way people will do that is that they get their knee sort of forced into kind of extension with a little bit of varus in their knee. And that's probably the two most sort of common ones. To get a lateral collateral injury is quite rare. I've got a video that I'll show you of someone doing one. Another common one you'll come across, ITB friction syndrome. Anyone come across that one before? So you've got your ITB, iliotibial band that runs down through the outside of your knee, attaches into sort of the lateral condyle of your knee. There's fat that fills, there's that word again, up underneath the outside of your thigh, and it's in runners, so they're getting repetitive sort of flexion extension of the knee. And particularly if they've got sort of shitty mechanics, all those structures can get sort of squished, compressed, and irritated. So it's an overuse running condition. Okay, anterior knee pain. So Osgood Schlatter we talked about, patella tendon we talked about. Has anyone heard of this? Chondromalacia, patella. It's patellofemoral pain. It's just that the kneecap itself has got some wear and tear behind the back of it. Okay, so it's a degenerative version of a patellofemoral issue. These two here, just two to pay attention to. So you've got this one here, so it stands for, SCFE, stands for slipped capital femoral epiphysis. So it's actually a hip issue, but they often come in with knee pain. So with your growth plates, you've got your femoral head, you've got your femoral neck, and then the sort of the stem of your femoral shaft. What it is you get the growth plate that bolts the neck onto the ball starts to get a slippage. And it happens in kids about 12, so again it's that same age, it's about 12, 13 year old. And it's actually an orthopedic emergency. So the way that you sort of tell that is, and you'll get people that get, again, insidious onset anterior knee pain, and there's no activity-related stuff that tends to set it off. It's just sort of there all the time, doesn't fit a pattern, all of those sorts of things. And the best way to sort of test it is to kind of have their knee, so rather than bend their knee up, you kind of bend their hip up without bending their knee up. So getting the hip up like this is a provocative thing for the hip. So if you have your leg out like that and you kind of push it across, then that's a way of sort of seeing if it's coming from their hip. Okay, but that's an orthopedic emergency. You guys will probably never ever see one of those acutely, but in the physio world it tends to happen. And there's another one called Perthes disease, which is another avascular necrosis. Again, but it's in an age-related one. So if you ever get in, the only thing you really need to remember out of this is if you get people in the sort of 10 to 12-year-old bracket who are getting weird anterior knee pain, they could just be being pork chops because they're teenagers, or they could be actually having stuff that's a bit more sinister. Okay? Alright, so here's just a couple of rehab ideas. Someone may have turned the lights off. Okay, so that's just practicing change, foot under the body, change your direction. Calf, outside of hip, glute med. Okay, this is where you're starting to transition them into kind of a little bit of impact. That's a thing called a sprung floor, so it's a pretty soft surface, so it's giving them some exposure to it, but it's not that hard on the joint. Okay, there's that calf stuff we were talking about, trying to get them so the calf is able, they can keep that nice ankle stiff. Okay, you see how he's never on his heels, trying to get it through our midfoot.
I'm listening.
So what I mean, graded exposure to fear. You wouldn't do that first off. Yeah, I've probably sold that squats are really bad now, but we actually do them. Has anyone ever done those? Okay, this is practicing that change of direction on the body. So that's just that graded exposure to the end stage. So this is not, by no means is not the end, but you're preparing them for the end. Okay, now what the hell does that have to do with the knee? Trunk control. Okay, so try this sometime. Stand on one leg, try and resist. Okay, if you can resist around that, it takes pressure off your knee. Okay, you see how there's that transition now, so we're getting away from slow, we're getting faster, starting to bring in impact. Okay, start adding external load on there, trying to add that sort of element of, duress on the body. Okay, get quicker and quicker and quicker. It's always better if you sort of try and rehab people in chinos as well. Looks like borderline abuse, doesn't it? Okay, and I've got one more if you want to watch this one quickly and then we'll wrap it up. There's heaps of stuff we do with that, like, again, try and use the calf as a way of unloading the knee. And that's so the bungee cord is like pulling them into the target, so it's actually sort of like creating a bit of over speed on them, a bit of duress where they don't want to be. Okay, I recommend trying this at some point. Alright, any questions? The brains of you are reasonably cooked, I imagine, by now. So, yeah, if anyone has any questions you think of it later, then I'll work with some of the people in here on a fairly regular basis, and Kelly can get in touch. So yeah, good luck with everything. If you need anything, just let me know.
Is she going to upload it, is it?